Great to have you, Dr. Bowman.
Nice to be here.
The other side of it is talking about breast reconstruction, especially, and the timing of that after a diagnosis of cancer and treatment for cancer. In that context, though we know that the procedure can play a big role in healing for these women when they look at reconstruction, what are the pros and cons of taking an immediate versus a delayed reconstruction approach after their surgery for the cancers?
Yeah, so I'll back up just a little bit just to give a little bit of context. So we now know in the country that about 55% of women who end up having a mastectomy undergo some form of reconstruction, whether it's in the immediate period or in a delayed fashion. Of those that end up having reconstruction, of that 55%, the vast majority are having implant-based reconstruction. It kind of comes in two flavors: implant-based reconstruction or autologous reconstruction, where we use their own tissue. Primarily the abdominal tissue, because most of the folks in our country are a little bit more on the rotund side, and they have that to donate. So I think understanding that part. Over the course of the last 25, 30 years, we've really been pushing for this to take place in an immediate fashion. There was some really antiquated literature out there that said that you needed to have a woman understand what it's like to not have a breast so she could really appreciate it. Clearly antiquated, clearly not the right thing to do in my opinion and in most people's opinion. So we're now really encouraging women that once they've been diagnosed, that they come and see a plastic surgeon to have that dialogue. So we have folks like Ari and Dalia Sadaloff and Stacy Ugrass at Pennsylvania Hospital who are very good at making sure that everyone that comes in with the diagnosis that they have a cancer that's going to require mastectomy at least have a dialogue with a plastic surgeon. Whether or not they opt for it is obviously a personal a dialogue that they have with that plastic surgeon and a personal decision that they make. But at least they're having a conversation with the plastic surgeon, and we really try to do it in an immediate setting.
You try to do it immediate, as
yes,
opposed to,
we do.
Because the decision often comes where people think that maybe they should delay. What are the factors that make you advocate for an immediate?
So I think it's a couple things. From a supratentorial standpoint, psychologically, not having to go without a breast mound, I think, is beneficial. I think from a technical standpoint, from my end, it's technically easier to do it in the immediate setting. They already have skin. We've improved our techniques as it pertains to mastectomy, where we perform nipple-sparing mastectomy or skin-sparing mastectomy, and we don't want that skin to contract down over a delayed period of time. So if they, when they perform the mastectomy, we immediately come in. We either do our free flap breast reconstruction or autologous reconstruction or implant-based reconstruction to take advantage of the skin that they natively have and is viable. So that's why we really try to do it in the immediate setting if we can. Great.
And I have to ask an offshoot question that you opened up when you mentioned or alluded to the rising obesity rates, because it alludes back to a conversation I had with Dr. Debs just earlier tonight.
Sure.
Have you found that in your own practice, just from the beginning of your training to where you are now, that the rising obesity rates and overweight rates have changed your approach in terms of, as you said, the availability of abdominal tissue? Have you basically seen a changing way in which your surgical options come before you based on the populations that you deal with in, let's say, in the last 10 years even?
Yeah, well, I trained for 11 years, so in the beginning, I would say that, particularly as it pertains to plastic surgery, there was much more of a focus on implant-based reconstruction. Right. As the weights continued to kind of climb, what we were finding is that the manufacturers just aren't making large enough implants. And that's what really pushed a lot of plastic surgeons to find some of these autologous options. The tram flap, as we describe, or the DIAP flap, perforator flaps where we use abdominal tissue, it's a great source of tissue. They sort of get a mini abdominoplasty out of it because we're taking away that tissue and then making new breast mounds with it. So I would say the fact that our population has gotten larger has probably pushed us in the direction of finding additional means of creating a breast mound.
Right. Let me ask you then about the roles of people that would assist from other specialties in your work. We spoke with Dr. Brooks about the innovations from the surgical oncology side. When in this conversation with the patient about doing an immediate reconstructive procedure, does the surgical oncologist get involved for you? When do you like to bring in the surgical oncologist?
Well, I usually see them on the tail end. So historically, they'll have their screening mammogram, something abnormal pops up. they will either be referred to their PCP or they'll be referred to their breast surgeon. At that point in time, they usually have the dialogue on the oncologic standpoint, on oncologic side, and then they refer them to me, and we have a conversation about what reconstruction really means, what their options are, and then we work in concert to determine when we can do a combination procedure. So usually I'm on the tail end.
On the tail end, okay. Another question that often comes up with regard to reconstructive surgery after breast cancer is how does aging affect the follow-up here? Are follow-up surgeries required? Do you have to counsel patients about how aging of the reconstructed breast is going to affect their outcome?
I would say, aging of the reconstruction, usually tincture of time helps lots of things, particularly as it pertains to scars. I always tell my patients, don't judge your outcome till you're 3 months out. Don't judge your scar until you're 6 months out. With the process of wound healing, the remodeling process takes about 6 months in order for the scar to fully mature. I would say with breast reconstruction, as it pertains to autologous reconstruction, where we do a flap, I think they tend to get a little bit better with time. With implant-based reconstruction, I think initially they can have a stellar result, but the implant doesn't necessarily grow with the body the same way that autologous tissue does, their native tissue, which I guess inherently kind of makes sense. So I would say when we've kind of tracked these ladies over time, those that have had flaps, I think they kind of maintain, where those that have had implant-based usually require some kind of revision after X number of years, probably about a decade.
About a decade?
Yeah, well, the implant manufacturers all say that the shelf life for an implant is about 10 years, and that's whether it's a silicone implant or a saline implant. When we do breast reconstruction, it's silicone that we use. In the cosmetic end, there are more options, saline versus silicone.
All right. Well, just as a parting thought, any other comments you want to add to a primary care audience from a number of the areas that we covered here, from cosmetic to reconstructive to breast reduction?
Yeah, I think I've got to put a little bit of a pitch in for on the breast reconstruction side, because I get a lot of questions about it. I do have a master's degree in public health. I have a lot of interest in healthcare disparities. And we do know that there are two groups that just aren't getting breast reconstruction at the same rate as others. And those tend to be our ladies of color and our ladies that are more seasoned, over 60. And I think it's multifactorial. Once again, I could talk ad nauseum about it, but I think some of it is patient education as it pertains to what they kind of qualify for. I know I've had numerous conversations, particularly with our ladies of color, who say, what are the economic ramifications of breast reconstruction? And I articulate to them the fact that because of the Women's Health and Cancer Rights Act of 1998, if they have insurance that is covering their oncologic care, whether it's their surgery, their chemotherapy, their radiation, those insurance companies are mandated to cover their breast reconstruction for the duration of their life. That also includes a balancing procedure on the other side. So say they present with a right-sided breast cancer and they need breast reconstruction and they're a good candidate for an implant-based reconstruction. We perform that operation, and then at the same time, or in a delayed fashion, we do a breast lift on the other side, and their insurance companies are mandated to cover that as well. So I just think educating our patients that these options are out there. These are things that they need to take advantage of. I think I would be remiss if I didn't mention that.
That's perfect. Great parting comment. Thanks so much for your time.
Thank you.
It's great having you.
Nice to meet you also.